This presentation is part of the series of lectures in cardiopulmonary rehabilitation course for the Doctor of Physical Therapy students, but applies to anyone looking for an overview of electrophysiologic disorders of the heart. This is just an introduction. In this presentation, we will review what constitutes electrophysiologic disorders, the basic types, and the prognosis in very broad general overview. This video has the major chapters hyperlinked in the description below for quick navigation to major elements. Let's get started. As we know, the heart has both contractile muscle tissue as well as electrical tissue. Cardiac electrophysiology essentially deals with the electrical phenomena of the heart. The electrical tissues of the heart respond to autonomic influences of both chronotropism as well as dromotropism. In chronotropic influence, it deals with the rate of the heart, whereas dromotropism deals with the rhythm of the heart. They usually go hand in hand together, so problems with one also reflect in problems with the other. So why do we get electrophysiologic disorders? Well, if we have damage to the electrical tissue due to ischemic events or muscle failure underlying that area or congenital causes among others, all of them can influence the electrical functioning of the heart. The disturbance of chronotropism and dromotropism lead to what we call arrhythmias. Arrhythmias is a lack of rhythm, and they can be simple arrhythmias and they can be complex. When there is arrhythmia, there is loss of cardiac output because coordinated movement of the heart suffers. And those are topics that we will also explore in ECG reading. Cardiac arrhythmias can be classified broadly into sinus arrhythmias, supraventricular tachycardias, atrioventricular junctional arrhythmia, conduction disturbances, and ventricular arrhythmias. Very broadly, sinus arrhythmia is an arrhythmia that is originating from the sinoatrial node of the heart. Their characteristics are it can be above 100 beats per minute or less than 60 beats per minute. It does reflect in severe bradycardia when the heart is beating at less than 50 beats per minute with occasional stopping, which is called periodic sinus arrests. Supraventricular tachycardia is any tachycardia or any fast rhythm originating above the atrioventricular junction. There are a number of arrhythmias which fall under supraventricular tachycardia, for example, atrial fibrillation and atrial flutter, atrial tachycardia, and premature atrial contractions. The characteristic rhythms are shown on the right. The atrioventricular junctional arrhythmias arise from the junction or the tissue junction between the atrium and the ventricle. We usually see junctional tachycardia and junctional rhythms. Junctional rhythms reflect the rhythm where the signal originates from the atrioventricular node instead of the sinus node. Conduction disturbances are impairments of signal transmission through the atrioventricular electrical tissue. These constitute atrioventricular blocks, bundle branch blocks, fascicular blocks, among others. And finally, we have the most grim prognosis arrhythmias. Those are the ventricular arrhythmias. Ventricular arrhythmias are generally life-threatening and require urgent attention, without which the patient will not survive. So, how do arrhythmias manifest? Arrhythmias can manifest in a whole host of ways, and it depends where in the heart and what type of arrhythmia is occurring. As you can see, there are a number of different kinds of arrhythmia, from not so concerning to very concerning. Therefore, the symptoms of arrhythmias can vary. At the very least, it can have fluttering sensation in the chest. Patient may report sweating. Pain in the chest can occur. Lightheadedness or dizziness may occur. Shortness of breath, and then fatigue. These are related to lack of adequate cardiac output. The functional impact of arrhythmias is essentially dependent on the nature of the arrhythmia. Again, for people with arrhythmia which is not life-threatening, it can lead to severe anxiety. Now, if the cardiac output falls because of uncoordinated movements, then the patient will pass out, and that is called syncope. Patients may report a sense of impending doom. This is very common in arrhythmias. And of course, they will have exercise intolerance. Some of the negative or undesirable effects include sudden arrhythmic death syndrome, or SADS, and cardiac arrest, where the heart just stops. Cardiac arrest is an electrical phenomena. So is sudden arrhythmic death syndrome. Keep that in mind. It is not myocardial infarction. Here, the heart just stops. There are a couple of different terms uh, that you should be familiar with. One is sudden cardiac arrest, and the other one is a sudden cardiac death. Sudden cardiac arrest is when the heart all of a sudden stops beating. And if an intervention, for example, defibrillation or spontaneous reversion is not done to restore circulation, then the patient will die. This event is known as sudden cardiac death if the patient does die. However, the use of SCD to describe both fatal and non-fatal cardiac arrest persists by convention. The specific causes of sudden cardiac arrest vary with the population studied and the patient age. Sudden cardiac arrest most commonly results from hemodynamic collapse due to the development of ventricular fibrillation, which is a ventricular arrhythmia in the setting of structural heart disease. The outcome following sudden cardiac arrest depends upon numerous factors, including the underlying cause and the rapidity of resuscitation. Most individuals suffering from sudden cardiac arrest will become unconscious within seconds to minutes as a result of insufficient cerebral blood flow. There are usually no premonitory symptoms. If symptoms are present, they are nonspecific and include chest discomfort, palpitations, shortness of breath, and weakness. To recapitulate, uh, a sudden cardiac arrest is due to malfunction of the electrical pathways in the heart and not a ischemic event. However, it may be triggered by an ischemic event to the underlying myocardium. So It is common to see it after myocardial infarctions or during the 24 to 48-hour recovery period after a myocardial infarction. There are other causes, but this is the most common. These other causes are heart failure and long QT syndrome, among others. Sudden cardiac death is manifested usually by loss of consciousness and absence of arterial pulse without prior circulatory collapse. The cause is usually a fatal development of cardiac arrhythmia, usually ventricular, and triggered by coronary artery disease and underlying ischemia. This is common in the middle-aged adult, and it may be the first symptom ever in approximately 25% of the patients. The cause is ischemia most of the time, triggering a fatal ventricular arrhythmia. Let's look at the investigations that are done in arrhythmia. As in many other areas of medicine, no one test is used as a confirmation of diagnosis or treatment decision planning. The most important investigations in arrhythmia evaluation remains the ECG, which provides an instantaneous reading of the rhythm of the heart. However, for untraceable or ECGs that fail to demonstrate a pathology, a prolonged ECG recording can be done over a period of time, and that is called a Holter monitor. Additional tests that can be done in this area are also listed, but the two most important tests are ECG and Holter monitoring. So how are these cardiac electrophysiologic disorders managed? So the management of electrophysiologic disorders are medical. They can be managed by drugs or by shocking the heart back to a normal rhythm, and that is called cardioversion. In patients who do not respond to either pharmacologic therapy or cardioversion, a permanent pacemaker can be implanted. Additionally, in certain cases of arrhythmias, surgical options are available as an intervention. The ultimate goal of drug therapy is to restore normal sinus rhythm and conduction in the heart. It prevents more serious and possible lethal arrhythmias from occurring. The antiarrhythmic drugs that are used will decrease the conduction velocity so as to allow more time for the electrical signal to travel, change the duration of the effective refractory period, and then suppress abnormal automaticity, where certain parts of the heart start beating on their own, leading to complete disorganization. The drugs that are used in arrhythmias are broadly classified into anti-tachycardia agents, which are drugs that prevent the heart from beating too fast, or anti-bradycardia agents, which are drugs that prevent the heart from beating too slow. Anti-tachycardia agents are classified under the Vaughan-Williams classification that goes from class 1, class 2, class 3, class 4, and other categories. In class 1 drugs, they are sodium channel blockers. Class 2 drugs are beta blockers. Class 3 drugs are potassium channel blockers. And class 4 are calcium channel blockers. You have or will review these drug categories under other conditions in cardiopulmonary rehab. Additionally, others category includes drugs such as adenosine, which is a very commonly used drug in critical care to reduce a extremely agitated or reactive heart. Also, digitalis is another drug in the others category. The four categories or classes of anti-arrhythmia drugs have subclasses, all of which is summarized on this table. You will notice that the class 1 drugs, which are sodium channel blockers, have 3 subclasses. Class 2 drugs actually does not have a subclass. It is only one group of drugs which are beta blockers. Class 3 drugs typically is one drug, which is amiodarone, and some of its other similar drugs. And then class 4 drugs are singularly calcium channel blockers, so any drugs of that class will be a class 4 agent. And finally, you have a mixture of adenosine, digitalis, and magnesium, which are used as an others category. You will also recall digitalis as a drug that is used as a inotropic agent in heart failure. Certain cardiac arrhythmias, usually the ventricular types or ventricular tachycardias, are best treated by cardioversion. Cardioversion requires shocking the heart back to normal rhythm, especially in patients who demonstrate hemodynamic instability and pass out. The technique of radiofrequency ablation is available for patients with persistent tachycardia of different types. In this, a catheter is threaded up to the heart to destroy tissue that may be causing abnormal signals in the heart. And finally, a patient with slow heart rate or heart failure or malignant ventricular arrhythmias may also receive an artificial pacemaker, which is what artificial pacing means. This is an image of a cardioverting um, instrument that can shock the heart back into normal rhythm. And this is a image of radiofrequency ablation being done on a patient. Another option for patients with dangerous arrhythmias include the life vest. The life vest is a personal defibrillator worn by a patient at risk for sudden cardiac arrest. It monitors the patient's heart continuously, and if the patient goes into a life-threatening arrhythmia, then the life vest delivers a shock treatment to restore the patient's heart to normal rhythm. Essentially, it works like an external defibrillator and may be used as a testing means to see if an internal pacemaker would be useful to the patient. LifeVest is a proprietary intervention and is only made by one company at this time. Now, patients who are candidates can receive a permanently installed pacemaker, and that is what a permanent pacemaker is. Prior to installing a permanent pacemaker, a patient may undergo a period of life vest to see if that is appropriate for the patient. Pacemakers can either pace the heart, but there are newer pacemakers that can also act as a defibrillator. So, some physical therapy considerations. There are always individual side effects in patients. There is nothing universal. The presence of any of the classes of antiarrhythmic drugs suggest the possibility of the patient going into arrhythmias. Proarrhythmic effects are known complications with class 1A and class 3 group of agents that were shown in the previous screens. Other concerns with drug therapy in arrhythmias include too much suppression of heart rate that may go into bradycardia or also cause dizziness and syncope due to reduced cardiac output. You will have BLS or basic life support training, but to deal with resuscitation of sudden arrhythmias, it requires advanced cardiac life support training or ACLS. The takeaway for physical therapists is that you should monitor the heart rate and rhythm closely in patients with a known history of arrhythmias, especially when you detect that they are on medications for arrhythmia. Proarrhythmic effects is a known complication of arrhythmia medication. It is indeed exactly opposite to what we want the drugs to do. The drugs which are supposed to be suppressing arrhythmia can actually also create arrhythmias, and that's why constant monitoring is important. The most common symptom of onset of arrhythmia is dizziness and fainting due to reduced cardiac output that also reduces blood pressure. How do we as physical therapists respond to consultations after pacemaker implantation? We will look at this in rehab associated with the surgery lecture. That is it for a very abbreviated introduction to a very vast subject. I will explore this topic in some more details in the review of arrhythmias in the ECG lecture, as well as rehabilitation after pacemaker implantation in the surgical approaches lecture. Thank you. Please do leave me comments below and do like and subscribe if you got an early orientation to the topic as was intended.